minutes, we'll be talking about AI in breast imaging. The history of AI in breast imaging dates back to 1960s when initial attempts at computer-aided image analysis were made. By 1998, it achieved FDA approval, and the earlier results were very promising. But in late 2000 and early 2010, data started emerging that computer-aided detection is not helpful or may even be harmful in clinical practice. Since then, AI has been evolving, and now it has found its application in a wide range of activities across various imaging modalities. Breast imaging has many unique features and characteristics which create opportunities for meaningful AI applications. This include the long-standing and uniform structured reporting and lexicon, the BI-RADS system, which has been there since 1993. There is mandated robust outcome and clinical result tracking system for breast imaging, standardized positioning and technique which allows consistency in the data set. There is large available data set for training due to the widely accepted population-based breast cancer screening. Also, the familiarity with and acceptance of the computer-aided detection since ages. But there are challenges as well. There is widespread adoption of digital breast tomosynthesis, and most of the data sets have been trained with the 2D mammogram. Also, there is variability in the imaging appearance between the vendors. The file size of DBTs are extremely large, causing data problem. The breast imaging interpretation does not rely only on a single modality, but sometimes on mixed modality. And the clinical information which is obtained from the patient, the physician, technologist are key for accurate interpretation, which cannot be integrated by AI. And there are other challenges for general AI, the ethical, legal, and the financial considerations, which will be discussed later. The applications of AI in breast cancer can be divided into early detection and diagnosis across various imaging modalities, the tumor characterization, that is the breast cancer staging, molecular subtyping classification, gene expression analysis, monitoring and follow-up for prediction of recurrence, pathological complete response, and survival outcome. The applications can be classified into interpretative and non-interpretative AI. The interpretative, the explainable AI, which includes the cancer detection, decision support, and response to neoadjuvant therapy, and non-interpretative AI, which includes the cancer risk assessment, density quantification, workflow triage, image enhancement, and image quality assessment. Beginning with AI for screening. We've all heard about computer-aided diagnosis system. This can be either only computer-aided detection, that is to localize the area of increased density or calcification, or it may be computer-aided diagnosis, that is the localized lesion is classified into benign and malignant. As we discussed earlier, the earlier results were promising, but the later 2015 results showed that the use of AI significantly reduced sensitivity, which was due to a lot of false prompts, which led to higher false positive rates, higher recall rates, and biopsy rates. This is an MLO view of the left breast, which was done with a conventional CAD, and the first one is that of the conventional CAD, and the second image is from that of the second one is the AI-based CAD. In the first conventional CAD, we see multiple prompts for the masses as well as triangle for calcification. In the AI-based CAD, only the area which was suspicious was prompted, which is this area, whereas the other regions, that is the intramammary lymph node the area of superimposed breast tissue, benign calcifications were not prompted. Also here, the conventional AI had flagged this area of vascular calcification, whereas the AI-based CAD did not flag this area, saving the false prompts. There are more than 20 FDA-approved AI applications, and these are some examples of vendor-specific models. This was a case of a 58-year-old lady who presented for screening mammogram, and in her right MLO view, there was an area of asymmetry with architectural distortion, which is better visualized in the magnified view. This was biopsied and was proven to be grade 2 invasive ductal carcinoma. But when her images from 2 years ago was reviewed and CAD was applied, this area was marked, which showed 93% chance of likelihood of malignancy. That is, if AI had been applied to this lady, the cancer could have been detected 2 years earlier. Also, AI provides heat map giving the likelihood of malignancy as seen in the first case, the red area showing increased heat map, that is the increased likelihood of malignancy. The second case also marked this area. This was a case of invasive lobular carcinoma. It also gives saliency or attention map, marking the malignant masses with red and benign areas and calcifications with green. This was a study which was performed in the capital region of Denmark. It was a retrospective study in which the population was divided into 2 cohorts who were screened before and after AI, and their study showed that AI improved the cancer detection rate. It decreased false positive rate. The recall rates were decreased by 20.5%, and the reading workload was also reduced by 33.5%. This was how they conducted this study, and for each case, they gave a score. The AI gave a score of 1 to 10, the likelihood of malignancy, and they kept a threshold of 5. So for a score of 1 to 5, it was read by a single radiologist, whereas a higher score was double read by 2 radiologists. So this was their results. And these are a few examples of the study in which this case had received a high AI score, and the area of this calcification was marked as 85% likelihood of malignancy. Since it had a very high AI score, it was double read by 2 radiologists who confirmed it to be vascular calcification, and the patient was not recalled for diagnostic assessment. This was another case in which this patient had received low AI score, and it was single read by a radiologist who marked this area of asymmetry, and this was compared to her previous mammogram obtained 2 years ago. This was clearly a case of developing asymmetry, and this is the correlative ultrasound showing the non-mass area. In this case, this area has been correctly marked as a high AI score of 89% likelihood of malignancy, and the subsequent ultrasound picture showing the suspicious mass. This was another trial, a randomized control trial, which was performed in Sweden, and here it showed that AI contributes to the early detection of clinically relevant breast cancer and reduces the screen reading workload by about 44.2%. This was another study which was performed in Korea, which also showed that there was significant improvement in the cancer detection rate without affecting the recall rate. So where does AI stand in screening of breast cancer? It can either be used as an assistant to radiologist, It can be used as independent second reader to human radiologists, and now the studies are undergoing if AI can be used as standalone reader for screening for cancer detection. But there have also been studies showing that AI has missed 14% of invasive breast cancer. This was a study, retrospective study, which showed that the reason for AI misses were dense breast tissue, non-mammary zone architectural distortion, and amorphous microcalcification. Beyond screening, AI can also be used for decision support. It improves the radiologist's diagnostic performance when a lesion or area of interest is identified. It gives a case score and a lesion score. The lesion score is for the individual area of abnormality. It gives the likelihood of malignancy, and the case score is for the overall case, the likelihood of malignancy. So it helps in identification and segmentation of breast lesions, characterization and classification into benign and malignant, second opinion for suspicious cases, and can reduce unnecessary biopsy. This can also be used beyond mammography into ultrasound-based AI tools, which can be either handheld ultrasound or the automated breast ultrasound, giving the results as quantitative and qualitative data. So these are just a few examples where this fibroadenoma has been correctly given its BI-RADS descriptors as oval, parallel, circumscribed, hypoechoic with AI score of 3, that is probably benign. And in this case, an irregular parallel, non-circumscribed, hypoechoic mass with a score of 4A. The other application is the breast density assessment. As we know, the breast density is a double-edged sword. It masks the sensitivity of the mammography, as well as there is increased risk of malignancy. So the breast density assessment should be more objective, so there will be consistency in determining the breast density, which can suggest supplemental screening, and this can also be included in the risk assessment models for better performance. These are the quantification tools, and here the density has been given as B. It also helps in the cancer risk assessment. That is, if the traditional earlier, the cancer risk assessment was performed by using the risk factors, that is the age of menarche, family history, genetic information. But currently, even the image and the image, combining image along with the risk factors have been used for the risk assessment, and it can give 5, 10 to even lifetime risk of the cancers, which can be, studies have shown the area under curve up to 0.8%. Also, it can help to prioritize the examinations, which can be read immediately, to characterize cases by complexity, replace the second reader at sites, offer double reading to enhance the workflow, and thick overlapping slice in DBT. So here we can see that the case score has been given here and the complexity has been given. So the findings, the cases which need immediate attention can be addressed earlier. Also, the overlapping slices can be made from the DBT images without compromising the image quality. And the image quality assessment can be done to check for the technical inadequacy and alert the technician to correct the techniques. And there are image enhancement techniques as well. So we can see here, this is the normal, and this is the AI-enhanced synthetic 2D mammogram, and the findings are more clearer in the synthetic 2D mammogram. Also, there are studies showing that AI can show prediction to response to neoadjuvant chemotherapy as we move towards precision medicine. This is a radiomic model where we translate the medical image into mineable data, and the AI will extract various informations. So the first step is image acquisition, Second step is the segmentation. Third is feature extraction. Just a few minutes, sir. And the fourth step being model building and analysis. With radiomics, we can distinguish benign versus malignant, classify the molecular subtypes and other clinical pathological indices, predict the axillary and sentinel lymph node status, predict response to neoadjuvant chemotherapy, and predict survival and recurrence. The challenges to radiomics include the generalizability of the data set, the interpretability as the AI gets more and more complicated, and convenience, that is how we can integrate the AI into our workflow. There are features of the AI which are mature and available, that is the density assessment and the cancer detection, and there are still some of the tasks which are still investigational, such as the response to neoadjuvant therapy and workflow applications. So if we can divide the role of the radiologist and AI, probably it will be easy to integrate the AI into our workflow. So as the fear remains, if AI will replace us, so I would like to end with a quote from Charles Darwin, that it is not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. So it is not man versus AI, but man and AI hand in collaboration. Thank you.